Welcome to AETCM, the Emergency Medicine Channel, Social Distance. So we received a 46-year-old adult male who is having external bleeding from the right upper limbs. Patient on arrival to the emergency, first is the initial primary service. Coming to the airway component, patient was talking in one full sentence. There was no gurgling, no stridor seen. No pooling of secretion.
Patient is talking in one full sentence, then patient doesn't have gurgling and stridor, no.
Yes.
If such a patient is there, patient cannot talk in one full sentence. So you finish it off saying that.
Patient is airway is patent, and as this is a trauma case, even cervical spine, there was no any signs of trauma to the neck, no laceration, no tenderness. He was able to move his neck in active movement was present. Next, coming to the breathing, patient's respiratory rate was 20 per minute and saturation was 100% at room air, and bilateral air entry was equal. Coming to circulation, patient's heart rate was 98 per minute and BP was 140 by 80 per mmHg. At here there is a hemorrhage in the right upper limb. And at this point, two large IV pore cannula was placed, and
Patient is having hemorrhage in right upper limb,
yes,
right?
Yes, sir.
What is your first thing to do?
First thing is to stop the bleeding, compressive bandaging.
Yes. So compressive bandage is the first thing to do,
Yes,
not
sir.
put two IV cannulas. First give some compression so that you can stop bleeding. Simultaneously tell the staff to put two large bore IV cannulas. Fine. So how will you give compression and stop bleeding in this patient? What define the lesion that you are seeing there?
Sir, the right limb below the knee, below the elbow, there is amputated limb. There is
the limb completely amputated?
Completely amputated, separated limb.
Clearly tell. Right below right elbow, right upper limb is completely amputated. Now, is it an irregular amputation or is it
It's
a
an
regularly
irregular
bordered amputation?
Irregular crushed amputated.
It's an irregular crushed amputation. So, why that is important? Why it is important whether it's a clean cut amputation or an irregular amputation?
Yeah, as because clean cut, we want to preserve the margin to say resuture or re-implant the limb.
True. And what about irregular?
Irregular crushed, we cannot, there it will be mangled, we cannot suture along the border, but still we can preserve
but that is not an emergency, right?
Yes,
this patient is not going to go for a reconstructive surgery in emergency.
Yes.
What is the importance of emergency in a mangled area? If you have a mangled, amputated limb, upper or lower limb, what is the importance that we need to understand?
We have to check for the nerve, like arterial flow where it is leaking, and try to compress the leaking blood vessel.
This is a amputed limb, so
Yes.
there is no distal part, right?
Yes.
You have a wound here, there is nothing below here. So the question is, where will you give compression? That is the question, isn't it?
Yes, sir.
Huh? So you don't have anything over here. Obviously, you can give a compression over the injury because there is nothing there to give. You have to give on the stump. But if you're giving on the stump, the question is, if it is a clear-cut injury, there is a stump there with anatomical markings in which you can give pressures.
Yes.
If it is mangled, the question is, where is the arterial cutoff?
That
You
we
don't
cannot
know.
find it. So here we have
Because
to.
since arterial cut happens, artery can retract inside. And if it is retracting inside, patient will have continuously blood flow from there. So there is no point in giving compression here because patient's wound might be here, but the bleeding artery may not be here itself. It can be higher up. So what will you do?
We should, like initial would be trying to use the bigger gauze based Gamgee to place
You
and
will
tie
cover
out
the
the stump.
wound area. What will you do to control the bleeding?
Apply tourniquet.
You apply
To
tourniquet.
tourniquet.
So this is a case in which a tourniquet placement is adequate for bleeding control. Tourniquet is the main measure here, not gauze or Gamgee pad or anything, not local area compression, it's tourniquet placement. Fine. So what type of tourniquet do we have to place?
First we have to place the gauze across the limb, and then we have to use a wood sling, any vertical object to tight it, the tourniquet. First a tourniquet, like a bandage is wrapped around the arm.
To prevent soft tissue injury.
To prevent soft tissue.
We have basically two types of pneumatic devices, right? We have pneumatic compression devices and we have mechanical compressive devices. Mechanical is the one that either we engineer out of it or we already have a mechanical tourniquet as such. Okay, mechanical tourniquet, if it is factory made or if it's a company made, it will have a rotating cylinder in which we can increase the tension. So we need to cover first of all, we need to identify the site in which you are placing a tourniquet.
It should be at the joint space, it should be above it, and it should be like, if the wound is, it should be nearer to the heart.
Proximal to the wound area, avoiding a joint space. This is what you are saying. Yes. Correct. In there, what we need to identify is also what is the size of tourniquet we are placing there. So that size of tourniquet should be able to be accommodated over there. For example, a patient is having a distal forearm amputation. Okay, distal forearm amputation. We have only this much area to place a tourniquet. But if our tourniquet is already a factory made tourniquet, it has determined sizes. Our tourniquet may not be holding in that area. In that case, we may have to go for a proximal segment. So question is, how are we applying the tourniquet? Is it factory made or is it, or we make it? When we make is when we use the wood or other metallic objects to tighten. That is to provide constant pressure over the area. Okay, but in a factory made thing, it's already a encircling device. You can tighten the screw, it will apply equal amount of compression over all the areas. Okay, fine. Then we have pneumatic tourniquets.
Like the BP cuff.
Like BP cuff is a pneumatic. We can use it as a pneumatic compression device for some time, but it's not a proper pneumatic compression device. What can we do? We can adjust the BP cuff over the upper arm and inflate it over the blood pressure level to suddenly stop the blood flow. But we can't keep it like that for a longer time because it will cause ischemia and severe pain for the patient. In the meantime, when we apply tourniquet, we have to have a surgical team ready to cauterize the arterial bleeding area or at least clamp the arterial bleeding area. Identify the mangled area to identify vascular access areas and clamp those areas because they can cauterize also. They have to take for surgery. For surgery, if they cauterize, they can reattach the limb, but they can clamp the area to prevent further bleeding. So how will you put a tourniquet? You don't have mechanical tourniquet, you don't have pneumatic tourniquet in your ER. How will you make a tourniquet in your ER?
First, we roll over the bandage across the limb, and then we tie one square knot, just like we tie a shoelace, but we don't apply the bow. Just one tie, we knot it.
Simple knot. You put a simple knot, wide simple knot. It shouldn't be a thin string or a thin.
Just a thread type. It should not.
Yeah, basically it should have a circumference to apply pressure over a larger area. It shouldn't be like a thin thread or a filament or something like that, because then the force applied, the pressure applied is over a very small area. It can have pressure effects over the local area. To prevent that pressure effects, means negative effects of pressure, we can apply the same pressure over a longer surface area so as to completely give pressure from all directions without having acute pressure negative effects. Okay, so
first one layer of the bandage, and after one square knot we put any wooden sling kind of object to tighten the knot.
Any solid object.
Any solid.
It need not be wooden, it can be metallic also, but a solid object is placed over the knot and a second knot is applied over it, which we rotate to increase the adequate pressure. How will you know you have attained adequate pressure?
When the bleeding stops.
When the bleeding trickles down and stops.
And still if the bleeding doesn't stop, we can apply a second tourniquet below it this time.
Okay. So this is the primary management in this patient. There is wound management is there for this patient because it's mangled. We need to tidy the area, we need to wash the area, we need to wash it with warm saline. Everything is true. We need to identify the artery to clamp it also, but primary management is tourniquet placement. This is the ideal patient for tourniquet placement because there is no clear-cut stump to identify the bleeding position, isn't it? We need time to explore and find the bleeding area. Fine. So you apply a tourniquet. Now, circulation, external hemorrhage, you have stopped. What else?
Along with that,
what is the current BP?
BP 140 by 80.
140 by 80, so it's pretty good. We don't have to think about hypotension as such. Okay, what is heart rate?
Heart rate is 98 per minute.
98 per minute. Okay.
Apart from that, like the putting in the two large bore IV cannulas and sending all the basic labs at this point of time has been done, and further going on with the disability.
Further going on disability, but in the here, since it is a amputated limb, you can involve the surgical team right now itself to identify the venous structures or arterial structures and clamp it down. That can be said there itself, because we can't apply this tourniquet and keep the patient for a longer time. We can, if we are not planning to save the limb, if we are not planning for a reconstructive surgery, we are planning to clearly amputate the limb and take it out, then it's okay. We can keep the tourniquet for a longer time. For example, this patient's the distal end is completely mangled, cannot be reconstructed, or is not available right now, or it's not fully preserved. Then we don't have to think about the end result. We can apply tourniquet and keep the patient. But otherwise, keeping the patient on tourniquet will cause local necrosis of the local tissues also. So to prevent that, identification of vascular areas and clamping is much more better.
And like apart from the preserved, like the limb which is there, the other amputated limb also we should take care of.
Yes, so if the bystander is bringing the amputated limb, what will you, how will you get hold of that, or what will you do for that?
Initially, we need to because there is an injury, we have to suspect that it will be infected with streptococcus, staphylococcus, such organisms also. So we need to rinse it with warm saline.
Is it only streptococcus, staphylococcus and all? How did his hand get mangled?
The event which occurred was there was a roti making machine which was
heavy machinery. Got
and
stuck inside a heavy machinery. So is it gram positive organisms we are concerned about? Is it only not gram positive? Is it only gram positive?
No.
It's heavy machinery, right? It's been using on a day-to-day basis. It's been oiled, greased, all these things are there, isn't it? So it's not only gram positive, it can be anything. Including Clostridium tetani, we should cover for. Especially if this is in heavy machinery. The same thing can happen in a road traffic accident. Patient can come with mangled hands, nearly amputated limbs. It's not only gram positive. We have to think about the debris from the roadside, mud, all these things. So gram positive, gram negative, all infections are possible here. So how will you?
First, we need to we should avoid multiple doctors touching it, so that multiple contamination would be there. A single doctor
should take care of
the limb, and it should be laid on a sterile area, and warm saline wash should be given. But if there is any fragments of the skin or any part, that also should be preserved. It should not be removed from the amputated limb, because later we can use for any skin grafting or any purpose. Apart from that, the other thing would be there using the tissue perfusion fluid. Like example is University of Wisconsin cold storage solution. So if you can find the amputated limbs arterial, like the limb, we can flush this cold storage solution through that, and we can help in preservation, so that we can think about transporting the limb to other place if we had to transport. Otherwise, in the ideal situation, in the usual practice, we can clean it, put it in cover it with a plastic cover, and that cover should be placed in a container containing of cold water and ice.
Yes. So keep it in a plastic cover and try to wrap it nicely so that not much air is inside it. If we can make it airtight, well and good. If not, wrap it tightly so that most of the air is taken out, and keep it in a
cold storage
cold
container.
storage container using ice. This is the most commonly seen thing. The thing is, we need to keep it in a cold storage area, not in a normal vessel or a normal bag or something. Cold storage area to preserve the temperature. Or else over time the ice will melt and temperature will hike up. There is no point in preserving the lip. So to maintain the temperature, storage situation should be assessed for.
The idea is to keep the tissue in a hypothermic temperature so that the viability of tissue remains. The first prolonged. The first tissue which is going to be ischemia is the muscle tissue. So the target would be to maintain temperature of 10 to 20 degrees so that muscle tissue will be preserved. And apart from that, when we put in this cold solution, anything, it should not be in direct contact to the tissue. Otherwise, because of the hypothermia, the tissue itself will get frostbite, and we cannot use the arm again.
That's why we cover it very well with the plastic wrapper and keep it inside, right?
Yes. And the other thing is the contents of the Wisconsin solution. Like ideally, the constituents mainly consist of phosphate, which is the buffer, which will prevent the ischemic metabolites. It is a buffer for that acidosis and that ions to grab. And magnesium sulfate is a cell membrane stabilizer, which is a constituent. Now, these two are the major components of this solution which can be used ideally if available.
Okay.
And the principle for any amputated injuries would be first doing the ATLS management to the person, then depending on the mechanism of injury, like the crush injury or the fine cut injury, preserving it. And initially when we are taking the care of the amputated, then only itself taking photographs of it, so that multiple times no need to open it for the other concerned specialties to see it. And at the same time taking an AP and lateral view X-ray at the same moment, so that further for the orthopedic side also it will be useful. And the temperature control is the major important, and if possible tissue perfusion fluid, and sending it to the plastic surgeon wherever the facility is available. These are the required for the amputated limb to be.
For this patient, what else will you do in primary survey?
For this patient in primary survey, other thing would be categorizing the shock, as there is a lot of.
Is the patient in shock?
Not in shock.
Okay. What type of, or in which areas would you suspect shock? If this patient had amputation, in which other areas would you suspect shock? Or we expect shock, not suspect, expect shock.
Like if it would be a lower limb injury?
Yeah, long bones.
Long bones, any long bone.
Lower limb or in the thigh area, if this patient had an amputation, kind of like picture like this, or a mangled area, we should suspect patients to be in shock, because much more volume can be lost over that area. But since this being in forearm, the amount of volume loss will be much more contained, unless there is a ongoing arterial bleed or an ongoing venous bleed, then patient might be.
Also, the limb should be elevated and put above the.
With support only we can do that, because patient already have an amputated limb. We can just ask the patient to keep it like elevated. No, we have to support and keep it elevated. We can do that. What else? Anything else?
Now, after that, we need to be ready with the, like supposing he is in the shock, to consider massive transfusion protocol.
Patient is not on shock right now. What else? What else for this patient?
Prep him for the surgery.
What else? Very important. Pain management. This patient is having an amputated limb. If we are not going to manage the pain, then there is no point. See, it's not about there is an amputated limb, we'll do all this surgery. Patient should be out of pain. It's not a simple fracture or a lacerated injury. It's one limb is being taken away, isn't it? Patient will be in severe pain. Pain management is one of the main things you need to do for this patient. Okay, that comes in primary survey. It shouldn't be in secondary survey or end of the management plan, and that should come in primary survey, especially for such a bad injury. What else?
Next,
what are the arrangements you will do for the surgery, or you told you will prep the patient for surgery? What are the main arrangements?
Arrangement of the blood products.
Blood product arrangement.
And antibiotic coverage, as it's.
Okay, so blood product arrangements. If you are expecting a massive bleeding when they remove the clamp, or massive blood loss is suspecting, you are suspecting, how will you arrange blood products? How
Like
much will you arrange?
the initial, as per the ARCM guidelines we have, is the initial we start with 4 units of FFP, then 2 units of PRBC, depending.
4 units of FFP and 2 units of PRBC.
Arrangement wise, initially 1:1 we need to transfuse.
If we are expecting major bleeding causing at least 50% of blood volume to be transfused, we have to arrange 1:1:1, isn't it?
Yes.
That is massive transfusion protocol. So 1 PRBC to 1 FFP to 1 platelet. That is what we need to arrange for this patient. We may not use it. Okay, that's what I clearly asked. How will you arrange for the surgery? They may not use it. It may be much less bloodied. They might have to use it. So when we arrange for it, we have to arrange 1:1:1. Transfusion to in here. Any of this patient doesn't have shock here. Patient's BP is 140 over 90, doesn't have tachycardia, heart rate is 98. So we really don't want to transfuse any blood products here. It doesn't matter whether patient has lost some blood. Question is the patient in at least stage 1 shock? No. Then do we have to transfuse? Not necessarily. Okay. What are the antibiotic coverage you will give to this patient?
Antibiotic coverage as considering to be mostly gram positive and gram negative, we'll start with
What is the ATLS recommended antibiotic?
cefirex.
Cefiberozone. What else? What are the other? If this patient was presenting with a road traffic accident, he got a crush injury when his motorbike was jammed against a car or a lorry. What is one other organism that you will cover?
Clostridium tetani.
What is the coverage you will give? So it's not only tetanus toxoid vaccination, you have immunoglobulins now. So you can give tetanus immunoglobulin as IM for this patient. That will cover acute infections, because even if you take TT vaccination, if it is a wound is already contaminated and all, a patient has a high risk for Clostridium tetani infection. That can be covered it off. Okay. Anything in the secondary survey was there other than the limb injury? Any other major injuries were there? No, it was isolated limb injury, right?
Injury.
Okay. So when you present these cases, detailed history, when we say ample history, that is what we mention is a detailed history. Unless a patient is brought to our ER by police or some bystander who doesn't know what has happened, everyone will let you know what it is. So you can tell it's a crush injury to the right upper limb causing uneven amputation. That is fine. Why? Because when the case initially started, it was like airways, C-spine, breathing. I'm not saying we shouldn't concentrate on that, but we already know the patient was having a heavy machinery-induced single limb amputation. We know what's the major thing that is happening here. We will check airway, C-spine, breathing and all, but it can be done on a parallel basis rather than a horizontal basis. Rather than a single doctor being there, we can finish it off with two on tandem and focus on circulation, because as long as we are taking time to evaluate the others, patient will be bleeding out. This is an amputated case. We are not talking about a lacerated injury. Lacerated injury is bleeding will be much more contained, right? So this is an amputated injury. So there is active bleeding. If active bleeding is there, ATLS is always telling us to give some amount of compression to prevent bleeding. It's nowhere written that you should not look at a bleeding area and don't do anything. You should only do airway, C-spine, breathing, ventilation, then only come to. It's not like that. Do not waste your time on unnecessary bleeding points, which is not going to cause hypotension or major blood loss for the patient. But this is a amputated limb. Patient can be having significant ongoing bleed. That ongoing bleed is there. We can give a compression along with airway assessment and C-spine. We don't have to do circulation first. We can give a compression. Okay. Okay. Other than that, plastic surgery took over the case for reconstruction. How is the patient now?
So right now, it had been vascularity has been regained, and even like nerve reconstruction is pending. It will be done like week by week. Slowly, they will be extending the nerve.
Okay. Okay. Thank you.